One of the things that we have not addressed well is cost. And I'm going to propose at the end of my introduction that Miami Breast 44 will require the speakers to tell us about the cost. And it might be the cost to the healthcare system, it might be the cost per patient per year, it might simply be something like the financial toxicities for the patient and for the system. Breast cancer is by far the most expensive component of the cancer healthcare delivery system in the United States. How will we afford this growth going forward, and can we afford it now? So the place to start is, how do we compare to other countries? And that is a problem because we are usually compared against 7 or 8 countries in Eastern Europe, Canada, Japan, and Australia. The problem is, and by the way, our life expectancy is about 4 years less than the aggregate for those 11 countries. But I'm going to argue that that's an apples to Volkswagen comparison. That is not a meaningful comparison. What drives the differences? So, excluding Australia and Canada, we are 6 times larger than the aggregate of the remaining 9 countries. We have had massive rural dispersion. There's striking topographical diversity from Arctic tundra to sunny beaches in Miami. Our public health structure functions radically different than these countries, either individually or collectively, and is largely local regional. We face racial, financial, and ethnic diversity that leads to the fact that we have first, second, and third world populations in significant numbers in the United States. We manage more genetic diversity. We manage more variability in social determinants of health, language diversity. There is historical structural inequity. We have highly decentralized insurance markets, mixed public and private sector financing, and all of this results in differences in disease epidemiology, access to, and delivery of care. This is a ratio. Dark bars are you and me, specialists, and the light green bar is primary care. And at the second to bottom row, you can see our ratio of specialists to primary care doctors. And it's striking. In many of the Western European countries, it's a 50-50 ratio. 16% of Americans get their primary care from emergency departments. 16%. That's massively higher than the rest of the world. That's true in Brooklyn, New York, where I work. My hospital, as the crow flies, is 3 miles from the financial epicenter of the world. 26% of our ER visits are patients who need primary care, who don't have a primary care doctor. And this is true across the United States. How do we compare to these 11 countries with respect to breast cancer outcomes? And the answer is we compare favorably. There's really not significant difference between the US, Australia, and Western Europe. But the systems are very different, and the strengths and weaknesses are very different. The US boasts widespread access to advanced treatments, higher screening rates. The challenges are that we have large internal disparities of race, income, and insurance. In Brooklyn, 55% of our patients are un- or underinsured. We are the largest Medicaid provider in the state of New York. There has not been a 1% Medicaid rate increase in New York in about 13 years. So how we will continue to deliver this care with a very stressed payer mix is not clear. In Australia, the strengths are strong national screening, universal health care. Their challenges are similar: large rural remote access gaps, and a large indigenous population to deal with. And in Western Europe, they have excellent screening program coverage, speed of diagnostic workup, and treatment access and national guidelines, which really helps their system. Why are our numbers not better? Well, this would be a 3-hour lecture. We have access and distance problems. Studies have shown that if you live 70 miles from a comprehensive cancer center, your outcomes are different. Your outcomes are worse. Stage of diagnosis is worse. Access to treatment is worse. We know that there are volume outcome differences. The more you do, the better you do it. And that becomes striking when you compare rural to urban. Screening and stage of diagnosis, which is on the bar graph, you can see the differences between rural and urban. Strategic implementation suggests that U.S. cancer performance reflects biology, understanding, and structural scale. Access architecture functions here as a survival modifier. And I think that's a really, really, really important thing to think about. We demonstrate among the highest breast cancer survival rates globally, but we also exhibit the largest internal variability in what patients get access to, and all of this comes at a strikingly high financial price. You have to look way up in the upper right-hand corner to find the United States, and this is a graph of cost versus survival. Currently, with conservative averaging, this is about $33 billion a year to the healthcare system, $33 billion. About 15 years ago, that number was $8 billion. We can't sustain this growth. We just can't. So we have these compromises we're going to have to consider. We reap an enormous innovation dividend with rapid drug adoption, early trial access, technology such as genomics that we are not limited to, and of course, academic density. But the financial toxicities, which are listed here, include treatment prices, insurance fragmentation, out-of-pocket burden for our patients, and high and rising administrative costs. So the question we're going to face is, what do we preserve that really matters? What do we fight for? And what do we begin to reimagine? So beginning next year, I'm going to require our speakers to include cost. I want to know, what is giredestrant? I can't spell giredestrant, but I want to know what it costs. Right, Rich? I want to understand, not that I'm against giredestrant, but we've got to start, we've got to quit ignoring the dollar signs, I think, because our patients feel it, and our country certainly feels it. I think that the solution is this Venn diagram, and we have all three of these covered at this meeting. Advocacy boils down to two things: women who have advocated for women and gotten high levels of breast cancer research funding going back to the 1990s. Secondly, women who have participated in randomized clinical trials in a selfless fashion and who continue. Yes, let's give these women a round of applause. These women have selflessly participated in trials for their neighbors and their daughters and their granddaughters. Secondly, intellectual creativity, and that's you, and that's our faculty, who continue to ask why. What can we do better? How can we improve this? And finally, our partners in industry, without whom none of this would really be possible. And so we've got all three of these circles represented for you here at Miami Breast. I'll be introducing the keynote speakers individually. I'm really looking forward to their talks.